Kia ora koutou katoa. Welcome once again to Manatū Hauora for an update on our response to the Omicron outbreak. Thanks again for coming. So I want to update you on the shift to phase 3 today, how that's going across the health system, including the shift from PCR to RAT testing, and also the current impact on primary care and on hospitals. First, I will give a quick outline of the current situation. The 1 o'clock media statement will have a comprehensive summary of today's cases, vaccination and so on, so that will be coming out as well. So today we're reporting nearly 20,000 new cases of Covid-19, with 373 people in hospital, 9 of whom are in ICU, and just under 100,000 active cases across the motu. Now, I know that such a high daily case number can be concerning for people to hear, and many of us will have whānau members who now have Covid-19. But it's important to remember that Covid-19 now is a very different foe to what it was at the beginning of the pandemic. And with 97% of new people over 12 years of age who have now had at least one dose of the Pfizer or another vaccine, for most people, Covid-19 will be a mild to moderate illness that can be managed quite safely at home. The big shift in moving to phase 3 is the change in our approach to testing. PCR testing has served us incredibly well for just over 2 years as we have sought to find and respond to every case of Covid-19 at the border and in the community. And that included it playing a major role in the control of our Delta outbreak that started last August and that we had very nearly got right in control of before Omicron appeared. But with thousands of new cases each day and nearly 20,000 today, we did reach the point last week where wide use of rapid antigen testing became both useful and appropriate. It also became clear that PCR testing capacity was not keeping up with demand. So pooling of PCR tests where samples can be combined and all tested at once has been used throughout the pandemic to help improve the capacity for PCR testing we have. Typically, samples are pooled with about 3 to 5 samples during the early stages of an outbreak to increase the processing throughput. For example, during the August 2021 peak of the Delta outbreak, some labs increased pooling to 8 to 10 samples per run. And we continued to use pooling in the early part of this outbreak. However, it becomes less feasible to pool when test positivity rates rise, due to the likelihood that there will be at least one, if not more, positive tests in each group of pooled samples. For example, last Thursday, that's 2 Thursdays ago, prior to the wider rollout of rapid antigen tests, 17 of the 20 DHBs across the country recorded positivity rates of more than 5%. Now, it's important to point out that prior to the 7th of February, so less than a month ago, none of our labs had ever exceeded that 5% threshold. The swift increase in positive cases right across the country effectively prevented labs from using pooling in the space of just a couple of days. At the same time, lab capacity was being affected by some other factors. There was lab staffing capacity as a result of the prolonged workload in responding to the outbreak and people needing to be rested. There were vacancies and some lab workers also tested positive for Covid-19 and couldn't work. There were some limits on reagent supplies because of global supply chains. All of that, it means it's now clear that we overestimated the number of tests the lab network could actually process once Omicron began to take off, and take off it did quite rapidly. So the rapidly increasing case numbers across the country and these other factors has led to a delay in the processing of around 32,000 samples. I've been working closely with the Minister and explained this situation to her, and our team's been working very hard over the last few days with the labs around the country. And I want to apologise to people whose tests results have been delayed. In some instances, but so saying, our labs are committed to processing all those tests. And those people will get a result even though it's been delayed. We have sent text messages out to those people whose results have been delayed, encouraging them, if they still have symptoms or have developed symptoms, to go and get a test. And of those who received the text, around 12,000 had gone and got another PCR, or most of them, a rapid antigen test. So when those results come back for people, in some instances, the result may be less sensitive than usual due to the delay in processing. There's a loss of sensitivity that may affect the negative result, but all positive results will be a confirmation of COVID-19. If we had recognised this delay a little earlier, we may have been able to better redirect and share capacity around the network. But once the samples are in a lab, it's very hard to take them out because they're in the system and move them to another lab. We've also used other things to help reduce this backlog, including sending just over 9,000 tests to Queensland over the weekend to be processed to help clear the backlog. I do want to emphasise that the delays are not the fault of our labs or the staff there. They have been working incredibly hard right through the pandemic and have done phenomenal work over these last few weeks. But we're addressing the situation. And just again to emphasise to anyone who had a PCR test on the 23rd of February or earlier and who is still waiting for your result, if you have symptoms still or have developed symptoms, then please go and collect a rapid antigen test from your local testing centre, or you can contact Healthline for advice. We are sending a text message today to all those who are affected. And again, most of these people have already had an earlier text message. So the shift to phase 3 and to the use of rapid antigen tests has made an immediate impact on relieving the pressure on our labs, and a big drop in the use of nasopharyngeal swabs and samples arriving at our labs. So it has got down to much more manageable level over the last 24 or 48 hours. We've seen strong uptake of rapid antigen tests by people with symptoms or who are close or household contacts, by organisations who provide critical services, and indeed right across the health system, to test both staff and people coming into hospitals and into other places like aged residential care to help supporting the safe delivery of care. General practices and urgent care clinics across the country, and particularly leading out in Tamaki Makaurau, are rolling out supervised rapid antigen tests, and they will now have unsupervised tests to hand out to people. And if people do need to pick up rapid antigen tests, the HealthPoint website has an increasing number of sites on there, or places on there, where you can go to collect them. Already more than 40,000 people have self-reported a positive rapid antigen test result. And in fact, of the nearly 20,000 cases today, only a couple of thousand of those were PCR confirmed results. The rest were people self-reporting rapid antigen test results. This is incredibly important for us understanding the extent of spread. And I want to thank those who have, and encourage everybody who returns a positive rapid antigen test to please upload that result online through My COVID Record. We now have plenty of rapid antigen tests in the country. We distributed over 5 million around the system in the last 7 days. We have 12 million in our central stores, and we're expecting over 16 million to arrive this week. So we are well supplied. The challenge is distribution, with some of the logistics networks staff being affected by the outbreak, but we are getting tests out as quickly as possible around the community. And just for those people who are going to pick up rapid antigen tests, what can you expect? Well, if you're unwell with symptoms, you will be offered testing kits for yourself and your household and whānau who may also be contacts. You will be given enough for 3 tests per person and provided on guidance how to undertake the test at home and how to record this in My COVID Record. That's if you go to a GP. If you go to a community testing centre, you will be given 3 tests per eligible person. Whereas if you go to a place where, for example, you're a critical worker and you go to a community pickup centre, they can be pre-ordered online, and you again will be given 3 tests for everyone in your household. So we're not just giving them to the person who is the case, they can take them home for their households to use. Okay, in phase 3, our health system has been preparing, and our hospitals are keeping up with the demand that is there. Again, 373 people in hospital today. what we've seen in the Auckland region over the last few weeks is that the average length of stay for people in hospital is quite short, 2.2 days. This is around half of what it was during the Delta outbreak. So people are going in requiring some care, mostly on the ward. The vast majority of people are not requiring any respiratory support either on the ward or in the ICU. We have good capacity across our hospitals are ready for this, and they can look after other illnesses. So please, if you are unwell and require care, ring Healthline, see your GP, or if it's an emergency, please do go to the hospital. At the moment, our hospitals across the country are about 80% of occupancy, which is actually a bit lower than it has been, and our intensive care units about 57% occupancy. So we have the capacity there. But only a small proportion of people with COVID end up in hospital. Most look after themselves and their family at home, and there are many others who are getting care from their GP or another community provider, and sometimes social supports as well. It's been great to see good uptake of self-service tools. Around 54% of people notified by text that they are a case in the last week have then followed up with a case investigation form online, and that helps us to target support to those who are at high risk. And at the moment, we've got about 90,000 people being managed through our nationwide clinical database, which is called the COVID Clinical Care Module, and that just makes sure that people are getting the care they need. Finally, well, New Zealand, like just about every other country in the world, has not escaped Omicron to date, but where we can be an exception is how well we minimise the spread and the impact of the virus and protect people as much as possible from it. What has helped us so far to do so well with this pandemic is doing the basics well, so please continue to do so. Wear a mask to protect others and yourself. Physically distance, practice good hand hygiene, and most importantly, stay home, don't go out if you're unwell. And please be particularly considerate of those who may be the most vulnerable to the virus, older people, people with disabilities, or with pre-existing conditions. There's no doubt the next few weeks are going to be tough. The health system can't do it alone, so thanks in advance to all New Zealanders for continuing to support our efforts to live with the virus on our terms. I'm now open for questions.
In terms of people currently in hospital, what's the breakdown between those who have Omicron and Delta?
So we don't know exactly of those in hospital, and with that short stay in hospital of around 2.2 days, it takes a wee while. There's a bit of a lag in us doing the whole genome sequencing on the PCR tests of those hospitalised. I don't have the exact breakdown, but in fact we've just got some up-to-date data on that, so I might circulate that afterwards.
It's useful to have that knowledge available to the public, given the differences, significant differences.
Yes, it does, and that's why we're systematically wanting to make sure the samples for our people hospitalised get to ESR and go through the whole genome sequencing. It's not urgent in terms of the clinical management of those people, but it is helpful for us to know just what the proportion of people who've got Delta or Omicron is.
And based on the information you have been receiving so far, what kind of symptoms are people who are not boosted having if they are sick, particularly with Omicron? I mean, do you know that yet?
Well, what I would say is whether or not people are boosted, I think the symptoms are similar, and we're seeing the most common symptoms are cough, sore and scratchy throat, runny nose, and not feeling that great actually, that sort of flu-y feeling, the whole body aches. But what we do know is that people who are not boosted are more likely to be symptomatic and more likely to experience more severe symptoms.
On symptoms, are you aware of any new symptoms where there's that children and adults haven't been presenting tummy bug-like symptoms and then testing positive? Are you aware of those kinds of symptoms?
I've seen some reports of gastro tummy symptoms, particularly in children. And we have seen that throughout the pandemic. Some people have what we call these atypical symptoms. So the symptom pattern has shifted. Early on, the thing that was really indicative of COVID-19 was this loss of sense of smell and taste. That doesn't seem to be a thing with Omicron. So it's more those upper respiratory tract symptoms. And that can include, I think, some people are reporting earache as well, quite a lot of earache, which is typical of an upper respiratory tract infection.
On the testing issue, Newsroom's been asking for a week
Yeah.
now about the backlog, the delays in getting PCR results. When did the Ministry of Health learn that this was a problem, that this backlog was growing?
Yeah.
And, how did you so badly overestimate your capacity there?
Yeah, so, and thanks, and we have replied an initial response, and there's a follow-up response I'm going to work on with the team after this. So I think there are two things I would say. First, the pooled capacity is something that we've been able to use to date, and so we've seen even in the Delta outbreak we were able to surge up to around 40,000 tests a day, and we had been increasing the capacity across the labs. Such that the surge capacity was up around 70,000, which can be sustained for a few short days. But that's very much pooled. Our unpooled capacity, as it transpired, we were aiming to get to around 39,000 tests a day by the end of March. And in one of my earlier statements, I may have given the wrong figure. I'm going to check with the team. But at the moment, it's around 30,000. But even to date, we've not really seen the volumes get that high, up to that 30,000 level. So we've been working with the labs to understand what was the gap. And I've asked also for an external review just to see what happened through that. And it's a combination of things. It was staffing vacancies and staff being off. Some of the new machines that were due to come in were delayed, and also there were some delays around reagents. And in terms of your question about how long we've known, really it's emerged over the last week, but became particularly obvious and acute late last week, and we've been working on it right through the weekend to see just what the opportunities were to move samples around to address the backlog.
Do you expect to see a sort of short-term bump in case numbers as those PCR tests are processed, or should it not really make a huge difference to the shape of the curve?
Yeah, look, I don't think it's going to make a huge difference because most of our positive results now are coming from rapid antigen tests. And so let's say there's around 30,000 samples to be processed with a positivity rate of, say, 5%, and spread over several days. I don't think it's going to make a huge difference in our case numbers each day. And what is pleasing to see again is that we're seeing widespread use of rapid antigen tests now. We've got high prevalence in the community, and that people are actually reporting those results.
That backlog, you said it was around 32,000 at one stage. What's it at now?
That's where it's landed at, is up to 32,000. So that's the backlog of samples that are at 5 days or more that are now being worked through by labs right across the country.
What was it at its peak when the problem was?
Around 50,000, but again the teams have been working over the weekend on this, and that included sending some samples to Queensland, making an arrangement for some to be processed there as well.
Hundreds of staff are sick or isolating across the health sector. Can you be sure that the sector will be able to cope with rising cases?
Yes, I am confident. We've prepared for this, and of course one of the things we really want to do is reduce the amount of other care that COVID displaces in primary care, general practice, as well as in our hospitals. And the first thing, of course, that gets delayed or deferred is our planned care elective surgery, and we're seeing that particularly in the Auckland region. And that will happen across the country as they deal with an increased number of cases. But our hospital capacity is there, our ICU capacity will be sufficient. But again, the number of cases, the number of people that end up in hospital will be directly related to the number of cases we have, and we still want to try and keep that peak as low as possible. So people avoiding spreading the virus is important for our health system to be able to cope.
Do you have an idea of what that figure is of the clinical workforce that is out for COVID-related reasons? And also, I guess, that limitation of surgeries and stuff, like what the percentage of that's also being impacted?
So I did hear a figure today. I think Middlemore were reporting around 15 or 20% of their staff who were not at work today because they were cases or they were household contacts or looking after others. And so what the hospitals do, and this is something they experience every winter because staff or staff family members go down with winter illnesses. So they've got the plans in place to move staff around and to reduce planned care right down.
So you're comfortable with about 20% loss of staff?
Well, I think that what I would say is that the DHBs have planned for and have plans in place to manage that. And what we do know is it will be particularly acute at this point in the outbreak and over this next week or two. And again, so the wind back of planned care will be temporary while they need to focus the beds and the staff on looking after acute people who are acutely unwell, and also to cope with the staff who are off work.
What if any use will there be for a 2-dose vaccine pass in the traffic light system after Omicron peaks?
Well, that's something we're looking at. There are three things that are really closely related. One is the COVID protection framework, and where we go once the Omicron has peaked, and in particular because it's very much predicated on the vaccine pass. So the second issue then is what does up to date, being up to date with one's vaccination mean now with Omicron? It seems really clear that includes a booster, so it's looking at that. But third is just what will the role of vaccine passes and indeed vaccine mandates be, because they're closely related once we get through this Omicron peak. And as the PM signalled, these are all matters that are up for she's sought advice on, including from Professor Sir David Skegg's group, but also we are looking at those to provide that public health overview as well.
How much does the protest activity influence your advice on that matter?
Not much.
Dr. Bloomfield, it's taking critical workers in Wellington more than 2 hours to access rapid antigen tests, and GPs are also reporting that they're facing delivery delays. When will that access get easier?
Yes, so I noticed there was a story in Wellington today, and I saw a photo in one of the publications of people queuing. So I talked to the team, and the issue again is not so much supply; it is the distribution out, and we are working every day with our district health boards to make sure there are plenty of rapid antigen tests out where they are needed. So we are addressing those sort of delays as they arise.
Does there need to be another site though? If it's taking hours for people to access?
Yes, it may require another site or more staff at the sites. And what we've seen with PCR testing is the labs are the DHBs are very good at surging staff in if they need to. So I'm confident they will respond to the queues, and also we're able to respond with getting more rapid antigen tests delivered out.
Do you have a sense of
I'll just sweep across this side.
What's the latest advice on the BA2 variant, and is that becoming widespread in the community? Do you know?
So I'll start with your second question. Is it widespread? We know that right from the start of our Omicron outbreak, we had both of those subvariants here, a BA1 and a BA2 sort of line of transmission. So I would expect we don't have any recent whole genome sequencing, but I would expect we have possibly a reasonably even distribution out there. I think in terms of what's the latest on it, one of the things that we've seen from Denmark is that, first of all, the vaccine seems to be just as effective, which is good, regardless of the subvariant. And also that if people have been infected with the BA1 subvariant, that provides a high level of protection from being infected, cross protection from being infected again with the other subvariant.
Actually, just on that, do you still need to isolate if you've already had COVID? So just say your flatmate has it and you don't get it, but a couple of weeks later you do. Does that person who was originally COVID positive have to isolate again?
No, they don't need to for a period of some months. I'll just say some months, because this is new to us, but they would have a high level of immunity and, of course, be at a very low risk of being infected and therefore at a low risk of infecting others. So this is a question that's been asked of me, so the advice is if someone's recently had an infection within the last 2 or 3 months, then they don't need to isolate again with a household family member. And while we're on the topic, we are looking today again at the period of isolation for both cases and household contacts, currently 10 days, to see if that might be able to be reduced. Our team is looking at the evidence again, what we're seeing from our outbreak in terms of the risk, and we'll be providing advice to ministers in the next day or two on that.
Would that possibly be going down to 7 days? Would you be comfortable with that?
Yes, it could be, and again, it's whatever the period of isolation, there's always, you're just taking a slightly increased risk that someone might still be infective at the end of their infection period. But of course, with the situation we've got with so many cases, and also we're seeing quite a big impact on critical services, that trade-off is there to be made. So I've asked the team to again look at just where the balance of risks and benefits is at the moment.
In terms of staff at hospitals who have been infected, do you have a sense of whether that's from transmission in COVID wards? Are staff who are treating COVID-19 patients getting infected by them?
I don't have any information on that. I'm really confident that staff over the last 2 years, particularly in those Auckland hospitals, have got really good at the use of PPE to protect themselves and, of course, their infection prevention control procedures. So I suspect, I would say that the vast majority of these people are likely to be being infected in the community because that's where we're seeing infections happening.
The outbreak has sort of been described as multi-speed, with Auckland having a lot more of the brunt of it now. Do you expect that elsewhere, other regions in the country will see a similar proportion of their population infected as in Auckland? It'll just come a week or two from now?
Yes, I think that's what will happen, and there are two things about that. First of all, that's what we see with flu every year when it's here. It sort of moves its way usually from north to south through the country. And second, it also gives us the opportunity to for the rest of the country to learn from the Auckland experience. So we're arranging sort of seminars and webinars so that Auckland clinicians can update their colleagues around the country in different specialties around just what they've learnt and how they can prepare and also manage when they do get that wave.
Could that epidemic curve sort of look like a two-humped one then, with sort of Auckland peaking and slowing down, and then the rest of the country coming up and pushing it up again?
It's possible. Let's see. And I mean, one of the things that is interesting looking at overseas places places in different states in Australia and even Denmark is, and the UK, they come down and then remain at a sort of what was almost a baseline level of infection. So it'll be very interesting to see where we settle there. But we're planning to expect a baseline level of infection and plan for that going into winter, because that may then be compounded by flu and others, things that are coming across the border.
The COVID-19 website, the How to Get a RAT section, had said that RAT home testing kits would have been available from the 1st of March, but yesterday that was updated to say early March instead. What's happened there? Do we not have enough to send to people at home? If you know, it might be
home. So if we're talking about testing kits that people can self-administer that are available, they've been available from last week through the community testing centres. They're the ones that are being given out. General practices up until the last couple of days had basically had the supervised rapid antigen tests.
So sorry, this is the home test you can order.
So that you can purchase?
The site said, yesterday it said from the 1st of March you'll be able to order RAT kits for home testing, but it now says from early March.
Right. Well, if it relates to people being able to order them to be delivered from the system, I'm not sure. I'd have to come back to you on that. What I can say is that rapid antigen tests are now available retail, and some retailers are making those available. And for many of those, like I think the Chemist Warehouse, you can order them and then have them online and have them delivered.
For a pack of 5, though, that's $45. Will there be at any point those packs to at least be subsidised for people that simply can't afford a 5-pack for $45?
Yeah. So anyone who needs rapid antigen tests, as I've said, there are many, many millions in the country in our supply. Anyone who needs them because they're a case or a household contact or as part of that critical worker exemption scheme is able to access them for free through a range of places.
What do you make of one of the protest groups which is calling on people to refuse to scan and wear masks, basically encouraging people just not to comply with any of the current health advice or restrictions around COVID-19?
Well, it's irresponsible, and it's really important, as I finished with my opening comments today, that we keep doing the things that have served us incredibly well to date and have meant that our death rate's one of the lowest in the world, and that is people getting vaccinated. Thank you, everybody. Fantastic effort, and our boosters are going up every day. Keep scanning. Masks are incredibly important. Please keep using them to protect yourself and others, and physical distancing. So that's the message from me.
Realistically, sorry, I'm just following that up. Realistically, are you concerned that there's a percentage of the population, maybe it's 5%, maybe more, maybe less, that are just living in this parallel reality where nothing you say seems to be getting through the alternative ideas of the world are so deeply embedded. I mean, how much does that worry you? Does it worry you?
Doesn't worry me because I'm hugely encouraged that 97% of New Zealanders who have actually had at least one dose of the vaccine are aware of what it takes to protect them and others and are taking that opportunity. So it's an incredibly small minority. So I think that that's fantastic. It's world class.
Do you think that the people who are in what you say is the 97%, do you think it's their civic duty to engage with those who still, believe COVID doesn't exist or believe in those theories? Is there anything that can be done?
Well, I think that if I can just encourage them to keep doing what they've done and keep doing what they're doing, that's what will get us through here. And again, appreciate the efforts they've taken.
On Novavax, when will I saw something saying that Kiwis will be able to get that in March?
Indeed, yes. So announcement today that ministers have confirmed the decision to use Novavax. It's approved. Our teams are now setting up the operational requirements to be able to deliver that through our system, and we're expecting deliveries in the next couple of weeks. So anticipating from mid-March, Novavax will be available as a primary course. It's a 2-dose course, not yet as a booster, but that would be further down the track anyway. I know there are a number of people who have been waiting for the Novavax vaccine, so I'm very pleased we've reached this point and we're now able to make that available for those people who have been not willing to take one of the 2 vaccines that we already have available.
Does the ministry know how many people roughly will take Novavax and hasn't taken Pfizer?
Well, I understand over 200,000 people who haven't yet had any vaccine. So that's the potential pool. What we saw with AstraZeneca was that actually the uptake was quite low. I think less than 10,000 people have taken up AstraZeneca as an alternative to Pfizer. And let's just see with Novavax whether the many people who've said they have been waiting for it to come forward and have it. I encourage them to do so. It's a good vaccine. It's an effective vaccine and it's a relatively safe vaccine. So once we have it available, please, if you haven't already had a vaccine, come and avail yourself of that opportunity.
Is there any advice from the government about, is the ministry preferring people to get Pfizer rather than Novavax?
Well, we've taken a decision, and ministers confirmed that. Ministers have taken a decision based on our advice that we will continue to have a Pfizer-based, so an mRNA-based vaccine program. There is good evidence that it is an incredibly effective vaccine, including against Omicron with a booster. Its safety profile is excellent, and it has served us well. And our advisors and ministers have agreed to continue to have a largely Pfizer-based program. We're not planning a switch to a Novavax or program based on another. I'm just going to come over this side again, down the back.
We saw yesterday almost 650 cases reported in Victoria University halls. How high risk are halls of residents, and what advice has been given to universities regarding this?
Yes, well, I can speak from personal experience that university halls of residence are high risk at the moment. So we have a nationwide super spreader event that is the start of the university year. So we're seeing this right across the Motu. And it's very clear that universities have done very good planning for this and have got in place the supports that students need to be able to safely isolate and to protect students that might not yet be infected from getting infected. So I'm very encouraged by, and indeed right across the education sector, from early childhood education right through, I think they've done a great job of planning for what we're now seeing.
How many cases have come out of Parliament's occupation today, and would you urge Wellingtonians to stay away from the protest where they can, as there are active cases among the protesters?
Yes, I think we were reporting at the end of yesterday the total of 17 cases. There are undoubtedly more because there will be people who haven't been tested there. Yes, I would encourage, as the police have been, for safety reasons, people not to Wellingtonians to stay away from the protest. And another reason to do so is to protect themselves from potentially being infected with COVID.
Travellers from this week are going to be saying, majority of travellers are going to be saying goodbye to MIQ. Can you tell me from Thursday what we are going to see MIQ hotels used for?
That's with my colleagues in MB, and they're in the process of providing advice to ministers on what will happen to MIQs from here. What I would say is we will still have some residual MIQ capacity because not everybody coming across the border will be eligible for to go straight into the community. So there will be unvaccinated people, there will be non-New Zealanders and others who will be coming across the border. But that's an active discussion. I expect the government will be thinking about that over the next week.
And what about the people who need it to isolate? They're
Yes.
also...
Yes, we're still retaining some capacity to support people from the community who may not be able to isolate safely at home. Yes, that will still be available for that.
Hospitalisations. What's the rate of hospitalisation for people who, is it, their COVID hospitalisations, but they actually presented with something else first?
Yes, okay. So two things I'd say there is our hospitalisation rates very, very low for in this current outbreak. So we've got around 100,000 active cases, 373 people in hospital. So if you use the approach of the number of hospitalisations over the number of active cases, it's well under 1%. But our team is looking at to see how other countries have calculated their hospitalisation rate so we can compare particularly with Australia. In terms of the whether people are there because of COVID or just happen to incidentally have COVID, it's hard for us to estimate that. But the one estimate we do have from Middlemore from last week was it was about 75, between 70 and 80% of people had presented with symptoms and they were there being treated because of their COVID symptoms. The others were there for other reasons and happened to incidentally have COVID infection. And that's consistent with what we saw in overseas countries that have had an Omicron outbreak.
Are we going to have to see clinical staff shift around the country to support possible gaps in different DHBs? Are people going to have to go to Auckland to support them?
Possibly, but unlikely, because I think we will see all DHBs will have challenges. As we can see, there are quite large and increasing numbers of cases in all DHB regions, and so there will be less ability for them to move staff around between DHBs. And also, DHBs are thinking about what they need to do to support community providers, particularly aged residential care in their own region, so that will be the priority for them.
In terms of people who present to hospital with non-COVID symptoms, like a broken leg or something, and test positive, that's sort of 15 to 20% he said, do they show up in that 373 figure, or would they be excluded from it?
At the moment, they're all included in that figure. And we have looked at and are trying to find ways whereby we could find that out and work out what that is in real time, but it's actually very difficult. But we're just aiming to try and get a weekly estimate of what that proportion is. Are there any final questions? I've just got one at the front here.
Do you know how many police have caught COVID from the Wellington protest? And is there any thought of supplying rats to the protesters, because one of the major difficulties has been that many reject testing, so it's hard to understand how far the spread is going?
I can't give you an answer to that first question about the number of police, and police would have to answer that. The local public health unit, regional public health, is responsible for that outbreak there. I'm sure that they would make rapid antigen tests available for people if they wanted to be tested, but there are also places nearby that they can collect rapid antigen tests if they need to.
Karen asks about loading up children's positive test results from rapid tests. They say, why is it that you can't do it over the internet and you need to phone through to a jam-packed health line? How concerned are you that you might be missing thousands of cases, or missing thousands of kids who are under 5 or not vaccinated and do not or cannot have a MyCovid login?
Right, okay. So can I look into that particular issue? Because of course that would be of concern if these tests weren't be loaded up. As you say, there is that alternative for people to ring in and register the result through Healthline. Of course, there's high demand there at the moment, so there may be a bit of a wait. But I'll come back and we'll check with the team and come back on what plans are in place to help facilitate parents uploading results for children. Technically, it may be a challenge, but I'm sure the team will be thinking it through.
Somewhat similar to that then, how much larger do you think infection is in the community rather than confirmed cases? I guess, we have the protests, we've got events where we know people aren't getting tested. How much do you think we actually have in the community?
I don't have an estimate beyond the case numbers we've got. What I would say is I think we're getting a good picture of the overall burden of cases and the spread across the country. And if I look at Denmark, which does a lot of testing and has had high rates of testing right through up to 180,000 tests PCR capacity every day, I think they've settled at around 40,000 infections a day. That's having got a peak and come off the other side. So I think we're detecting a very good proportion of our infections in the community, but we will be supplementing that with some modelling as well and our wastewater results. And I'll just need we'll find out an update this week on when we're likely to be able to find our sort of estimate of what proportion of cases we think we're getting through our testing.
So you're comfortable really that it's not like, there's double that are getting missed or something?
Well, it could be. I mean, we could only be finding a third or a half of these cases. We simply don't know. But I think if you look at the rapid rise and the fact that we are capturing 20,000 cases in a day here in New Zealand, and we've got 100,000 people we know are active cases, and from probably your own understanding of what's happening in the communities that you are part of, I think we're getting a pretty good picture of what the burden of infection is out there. Just two more questions, one down the back.
Just based off your answer to my last question, you said you're aware of the risk of falls based on personal experience. What do you mean by that?
Oh, well, I've got a family member who's in a hall of residence so the picture is the same right around the country in all the university halls of residence. And I guess the point I was wanting to make is it's really clear to me that that the halls had made good preparations for and are dealing with the situation really well.
I've got a question about the testing. The 32,000, is that all over? Who are these people? Is that all over the country that they haven't received the results? And how sure are you that it won't happen again?
Yeah, it's largely Auckland based, with also some in the Bay of Plenty. So the particular issue, the issue where the backlog happened quite quickly and was quite extensive, was in Auckland. But those Auckland samples are being shifted around the country and being analysed around the country. So it's mostly been an Auckland issue. And so saying Auckland was where we rolled out the rapid antigen test actually starting over a week ago, even before the shift to phase 3. We're very confident it won't happen again because of our rapid antigen test supply, and that being the main form of testing. And also we do continue to build our lab capacity.
So it was due to the delay in the rapid antigen testing?
No, it wasn't so much that. It was just it was more that we were, I would say we were a day or two late in recognising how quickly things were going up, and then and the point is once the samples are in the lab, it's hard to take them out and redistribute them. So we still had capacity across the network, but we didn't have the opportunity to redistribute them, and probably if we had started to do that a day or two earlier, then we may still have had a backlog, but perhaps not such a big one. But as I say, the labs are now processing that backlog. People are being messaged, and many of them taken the opportunity to go and be retested, the majority with a rapid antigen test.
Would a prevalence survey be useful in establishing that rate that you were talking about of how many more infections there are for each case?
Yes, and I think there will be a point quite soon where we will want to do a prevalence survey. My view is that would be most helpful after we're coming off the outbreak. I think we can combine the number of cases with what we're seeing in the hospital and healthcare system impact as well. But I think a prevalence survey will give us a good indication of what proportion of the population we're infected, and retrospectively will give us an idea of the number of cases we might have had and the level of residual protection we've got in the population. Thanks very much for coming up. Appreciate your time.